one and all to Mangalore. Rather, all of us in IADVL know that we have the special interest groups in various subjects. And this time our Karnataka branch has taken 3 of the SIG conferences. And this is the, and this is the 3rd in the list of all the 3 SIG conferences this year. And rightly, Hansen's disease SIG conference has come to the, I would rather say, the earliest place which was dealing with Hansen's disease in South India. And aptly they have selected a topic that CME is on Hansen's disease and its challenges in the 21st century. And to start the day, we have a stalwart in the field of leprosy. That is Dr. Vivek Vasudev Pai. He is the director of the Bombay Leprosy Project. He first joined over there in the year 1987. Then slowly ascended up the ladder. And he's taken over as the director in the year 2007. Rather, he's one of the distinguished personalities in the field of leprosy all over the world. His overseas experience is he was a clinical research fellow in UK for 1 year in the year 1998. Any publication in the journals regarding leprosy, you can see his name. Rather, he's got hundreds of publications on leprosy as well as contributions to the literature, either the textbooks or whatsoever. And even in our IADVL textbook, you might have read in the topic on leprosy, he is the contributor. Having traveled all over the world and having attended a lot of conferences, his services are used by almost all the Asian countries for advice about how to tackle leprosy and its various challenges in their country. And in our country, Gujarat, Maharashtra and the northeastern states are totally under his advice regarding management of leprosy. And he's been honored by having the post of WHO advisor, and is also a member of the Technical Resource Group Committee of NLEP. So, dear friends, this highly distinguished person in the field of leprosy is over here. Let us listen to him carefully, and if you have any practical challenges as well as any theoretical doubts, he is the person. He determines the MDT regimen in the country now. So I request Dr. V.V. Pai to take over and addresses on management of reactions, key challenges and what's new.
Its wings into field of medical education. It's a tremendous achievement way back in 1890. In fact, it is 1880. So, congratulations on this occasion. And I must thank the organizers, Dr. Nandakishore, Dr. Ramesh Bhatt, Dr. Narendra Kamath, Dr. Jyoti, who have been coordinating this program, especially under the banner of IADVL Karnataka branch, SIG Leprosy, which I thought it would be prudent to have this meeting. SIG Leprosy has been, under the IADVL, has been conducting several programs. I'm not particularly very happy with the CME programs are being done, but then we would like to do something tangible in this. And by tangible, I mean that especially our President, Dr. Mysore, is very much concerned with putting up a status paper as far as NLP is concerned. So we have been working in this direction. In fact, there is already a questionnaire-based investigation where we would like to tap the number of cases in the private domain or in the medical institutions which do not find a place in the national statistics. So with this preamble, I will, today the topic, I'm particularly glad with the theme of this meeting, Hansen's disease and its challenges. In fact, there have been several meetings in the last year where I have been also a participant in that. The challenges that have been discussed on several fronts, and clinical challenges and challenges with respect to reaction and nerve damage, because that is the paradigm shift in the program. We have, you are aware of that the decline of cases, the prevalence has been declining, but there's an area of new case detection which is static in the national scenario. And at the same time, there have been other issues where the burden due to the clinical disease has been a great area of concern. So I thought I would talk about this particular challenge, reactions, and to share with you more of a practical experience, what we have been experiencing at Bombay Leprosy Project over the last 3.5 decades. So at our center, being a referral center for the last 10 years or so, post-elimination, that is post-2005, there have been wealth of cases coming, there have been a lot of cases coming with problems. And that has given an opportunity to understand the problem in a much better and a more detailed way. So we have been gathering and collecting experiences. Data is one aspect, but then the clinical experience, whatever has been accumulating, I thought that would a nice platform to share. I did share this in the Dermacon in February, which Karnataka branch hosted that. Now this is a welcome news. Just before coming to Mangalore, this news came in Times of India, and as you see, the government, the current government has passed a bill. There have been several obsolete laws which have been derogatory to some extent in the country, and one such bill is the government moves to repeal the Lepers Act along with 294 other laws. This has been a very the 1898 Act, and the bill has been moved in the Parliament, and soon it should be into a law, and then it will do away with those derogatory laws that have been exceptionally discriminating against the persons affected with leprosy. So that's a good news. And so reactions, as you know, is one of the most challenging clinical problems. We have still not understood a lot of issues related to that, though we are able to manage, or we have made some progress and in management of reactions. Why they are important is basically the propensity to nerve damage, the unpredictability of the reactions. Why I say this? Because we have been seeing this type of problems much long after stopping treatment. So there are still gray areas on these aspects, and most importantly is the alertness, or to exercise vigilance on the part of treating physician, treating clinicians, or in the peripheral health setup to look into this, so that you make an early diagnosis, as the dictum goes, early diagnosis and treatment, which will do a lot more good in preventing the sequence of events that would follow. Most among them is the type 2 reaction, but type 1 reactions, as you know, which is more, the diagnosis is more based on this pre-existing or new skin lesions. There have been nerves becoming tender, the crop of fresh painless lesions appear, a sudden edema of hands and feet, and more importantly the nerve function impairment that happens suddenly or over a period of time. Now, type 2 reaction is one more an area of real clinical problem. Why I am saying this? Because we are experiencing practically various types of ENL reactions. In fact, there is a group now, it is called as Enlist group. The countries, at least about 7-8 countries have come together, particularly India, Brazil, Ethiopia, and so many other countries, where we formed a group, an expert group, a research group, to look into these problems. There have been several gray areas in ENL reactions, and to look into the genetic aspects, why some individuals develop, why some individuals do not develop. How do you score this? There have been some literature, but then it's not full of information. So how do you severity, the grading of severity, and the drugs, which I will come to little later. These are some variants of ENL reactions which we often see, and that brings me to, you may ask, can we not predict reactions? The unpredictability which I mentioned earlier, which is really a concern, and therefore there have been several studies, serological studies, serological markers. You will find a lot of studies in the literature, but the problem is that none of them have been useful to a treating clinician. There have been no dogmatic cause and effect relations. Dr. Shetty is here. We have been doing a lot of laboratory studies, and particularly cytokines, interleukins, and things like that. But to a great disappointment, that these studies have not thrown light. So that boils down to clinical markers only. So a clinician has to base his possibility of identification of a risk factor, which patient would be posing a risk to reactions, is basically on the clinical markers. So here are some of the list, the borderline group, and the BI more than 3+ in multibacillary lepromatous or BL patients. You have patients with lesions on the face along the course of nerve trunks. We have patients with extensive disease, the multiplicity of the disease and the nerve involvement. You have intercurrent infections. There have been schools of thought on this. There have been a lot of exchanges on something called as, if you are, I don't know how many of you are aware of this, there's a medium called Salvatore Noto, and which exchanges a lot of information all over the world. So people put up their views and thoughts. And so there have been schools of thought which have been obsessed with this kind of factor, intercurrent infection, parasitic infestations, and hormonal changes, trauma, surgical intervention, which precipitate reactions. So we often jump to the management, but then I would say just hold on before you jump, that look at these factors, handle these factors, address these issues, and then come to the specifics of the management. Some flow diagram would help. We thought we tested in the field also, and then we thought we can sort of crystallize this. So the risk in relation to nerve damage particularly multiplies with the number of skin lesions, as I mentioned earlier. Then you have nerve thickening and no nerve thickening, and so this the risk gets divided. Then you have the moderate risk tender nerves, and the nerve function happening quiet nerve paralysis. QNP stands for quiet nerve paralysis, so the risk multiplies when there is tenderness and there is a nerve function impairment. When there is no nerve thickening but the nerves are tender, and still you can get quiet nerve paralysis and there is a nerve function impairment. So the risk multiplies, and therefore the examination at periodic levels is very important. So this classically exemplifies what I've been saying is, look at this nerve, so cord-like, so rope-like thickening, the multiplicity of the nerves along the course of nerve trunk predisposes this particular individual to the risk of nerve damage. Now, one of the contributions of this research group, which I mentioned, the N-list group, is basically to severity scale. Now the scaling has been done based on so many other issues. We had a brainstorming session on this, to how to grade this, and every item has been taken into account, particularly the pain factor. The pain is measured with the help of visual analog scale. The patient is asked to identify where exactly he feels. I'm talking of overall pain. I'm not talking of neuritic pain or a lymph node pain. The sense of well-being, which is based on that modified Arizona scale, and this is again graded from 0, 1, 2, 3. Then you have fever. Most often patients come with an history of ENL. They may not have a fever at the time when you examine, but there is a history of fever. So you look at the history of fever, you ask, there is a history of no fever now, but history of fever in the last 7 days. So that grades the patients. Similarly, grade 1, score 1, score 2, and score 3. Then we have number of skin lesions, ENL skin lesions. Now you have to virtually count the number of ENL lesions, and therefore grade accordingly. Then you have the inflammation of the skin lesions. You have redness, painful, complex. Complex meaning there have been erythema necroticans, multiforme, pustular necrotic, ulcerative reactions. And you have peripheral edema. Depending on the sites, face, hands and feet, you have bone pain. Patient often complain of bone pain, the tibial tenderness, and you have to score them accordingly. Inflammation of joints, you have eye inflammation, orchitis, which is often not looked into, and there again we have graded them into 0 is none, tenderness, pain on walking or movement, and pain at rest. Lymphadenopathy, I'll show you some of these cases in the clinical photographs. Nerve tenderness due to ENL, and the number of nerves. What happens is the patient has an existing nerve function impairment, suddenly develops a bout of VNL, and there is that precipitates a new nerve function impairment, and that will have to be assessed and scored accordingly. And you have urine analysis for proteinuria. So these are various items that have been, this is under again still, you will come across Dr. Ramu's score earlier. And there are other scores also. So all that has been taken into account and then crystallized into this particular scoring form. This will have to be tested. This will have to be tested. So, and then we plan to collect the data on this from the different centers. This is a visual analog scale for rating of the pain. No pain and the worst ever pain. Similarly, the sense of well-being, the very poor sense of well-being. Then to score the nerves, the involvement of the nerves and the peripheral nerve function impairment in the hands and the feet. In this particular investigation, we have taken up this 2-gram monofilament for testing the nerve function in the hands, and in the feet, the 10-gram monofilament in the feet. And that is as far as sensory assessment is concerned, and the motor assessment is the MRC scale, which you are all aware of. So, coming to the management aspects, the drugs for management of reaction is basically prednisolone is the drug of choice as a major immunosuppressive therapy. And however, you will find there have been a lot of variations in administering prednisolone or steroids. I find there have been not much of studies into this, and therefore some optimization of the steroid schedule has to be done. The WHO has given in the guidelines, in the program guidelines or in the WHO guidelines, a schedule which is here, and that is a tailor-made schedule for field work. It's very, it's a kind of fixed regimen, and here you will find tapering every 2 weeks and tapered over a period of next 12 weeks down to 0. But it was designed more from a field angle, where the patients are quite distant and quite remotely located, and you don't have an expert coming into the picture, and therefore the workers can plan this type of schedule. But if you look at the data, there have been a lot of recurrent